I was supposed to talk about the MS diagnosis after treatment, but because we can't do an MRI or a diagnosis without MRI, we decided to change the lecture. So it will be a little bit of repetition after the talk of Vera. Yeah, so what about diagnosing MS? For that, I wanted to present you a typical patient from one of the outpatient clinics. And this typical patient is a woman. She is 25 years old, and she was referred to us because of a tingling sensation she had in the legs. And it started in her feet, and over a period of 2 weeks, it ascended up until her stomach area. And what she felt, that was, well, it was a tingling sensation, but she also couldn't feel the difference between cold and hot water anymore. And with this different sensation in the feet, she also had slight problems walking. Her medical history was only migraine, and her medication was none. And at neurological examination, we found indeed a diminished sensation in the legs, also increased reflexes, and the surprising thing was one pathological reflex that you typically see with central nervous system problems, spinal cord problems, and that was a pathological foot reflex, the Babinski reflex. Now the question was, obviously, could this be MS? And I think in these types of patients, there are 4 questions that you have to ask yourself when you consider an MS diagnosis. So the most important one is the question if the clinical symptoms, the clinical features are typical of demyelination. For example, if you have an 80-year-old person with acute loss of every strength in one side of the body, it's not typical of demyelination, it's typical of a stroke. So every patient has some sort of typical features. Then, of course, very important nowadays, the question if there is objective evidence of CNS demyelination on any imaging modality. That will not be CT, so for that we will need an MRI, but there are also some other examinations, for example, the eye, the optical coherence tomography, that can show signs of demyelination. Then in MS, as I said already, the hallmark of MS is that there is dissemination in time. So you would want to find dissemination in time, and that can either be done clinically, so multiple symptoms over time, but also radiologically or in biomarkers indicating that there is a high risk of a next event. And then lastly, always a difficult one, we will talk about that in the next slide. Is there a better explanation? Can there be other causes that you want to rule out or that you want to think of before you make a diagnosis? So going to the diagnosis, Farah also taught us that the diagnosis is based on 2 hallmarks. We have dissemination in time and we have dissemination in space. And that is basically the most important thing in the MS diagnosis. So what does that mean? I've depicted here the 5 typical localizations, which you will know by head tomorrow. So it's the optic nerve, it's the juxtacortical lesions, the periventricular lesions, the brainstem and the spinal cord. And the dissemination in time you can prove either clinically, so by the symptoms, or by MRI, or by inflammation biomarkers in the CSF. And this is a form of clinical dissemination. This is the graph that I already showed you this morning. So if you have multiple episodes, for example, 3 episodes of visual problems, walking problems, and double vision, over time, you could make a clinical diagnosis of MS up until the new diagnostic criteria. And as I also said, it can, well, either be recovered fully or with some sort of residual disability, as you see here in the lower part of the graph, where you see that after each relapse there is some sort of neurological symptom, disability left.
Eva,
yeah.
Is one of these symptoms enough to diagnose, or do you need multiple of these also?
If you want to make a full clinical diagnosis, you also need 2 episodes in 2 different systems of the central nervous system. But of course, we now have MRI, so we always make an MRI. So I think it's very seldomly seen that we make a diagnosis based on clinical grounds alone. But I know there are countries who have less access to these healthcare resources, for example in Africa, and there you need to wait until you make the diagnosis. And that is also part of the reason that you see underdiagnosis, I think, because you have to wait for a longer time, sometimes even years. Yeah. But now, of course, we do imaging and biomarker research. So if you have a person presenting with one clinical symptom, the first thing you do is an MRI or investigations of the optic nerves, or to prove dissemination in time. If you haven't seen that on MRI already, you will do a lumbar puncture for CSF biomarkers. So this is what we also have seen already. This is the MRI. To prove up until now dissemination in space, you need lesions in 2 out of 5 locations. So here you have the juxtacortical lesions, the periventricular lesions, the Dawson's fingers again. This is the same picture I think Farah showed with the infratentorial and the brainstem lesions. You have the spinal cord lesion here, and here it's more difficult to see, but this is an optic nerve that is affected, that you can see based on the hyperintensity here in the optic nerve compared to the gray matter. So it should be this type of gray, but it's the gray matter type of gray. So this is the dissemination in space. And then in addition to dissemination in space on MRI, we're now moving into the time that we can also, or that we also need to look at the optic nerve, because the optic nerve can also be included in the dissemination in space. And we were discussing the OCT. This is an OCT. I think it's not yet available in your clinic. You were buying one or you have one?
No, we have also.
Okay, yeah. And do you also have access to OCT as the neurology department?
Yeah, we have an OCT machine
Okay.
in Istanbul University, not in the ADEM hospital, but if we need, we can access.
You can access it, yeah, okay, yeah. Yeah, because we have an OCT is generally done in the ophthalmology clinics. It's this machine for anybody who doesn't know it. And you make a scan basically of the retina, of the nerve fiber layer of the retina. And you can do it in different areas. This is a rollout of this circular scan. And what you see here is that you can see the different layers, the different nerve layers, the different retinal layers very nicely. And the idea is that if a person has experienced an optic neuritis in the past, that you see thinning of the retinal nerve fiber layer. And that is indicative of an optic neuritis in the past. And the idea is that if people have visual complaints that are due to an optic neuritis, it has to be abnormal at least 3 to 4 months after the event. And this is an example where it is abnormal. So you have the right eye on the left eye on the right, and you see in the right eye that was unaffected that the average thickness here is within the green area, so that is the normal thickness. And you see there in the left eye, and perhaps I can point it out better here this way, that if you look at the retinal nerve fiber layer thickness, that it's below the normal limits. So if you make this scan 4 months after the visual complaints, and you see that there is a retinal nerve fiber layer thinning, that is objective evidence of an optic neuritis. Having said that, we can also see this in patients that are asymptomatic. So you can also see retinal nerve fiber layer thinning in patients who have never had any visual complaints. So you can use these abnormal OCTs in conjunction with abnormal MRI of the optic nerve to prove the involvement of the optic nerve in patients who have not had any symptoms of the eye. And that is different now compared to what we had in the previous diagnostic criteria, where the optic nerve was in if a patient had symptoms, but not if you had asymptomatic changes on imaging. So then the dissemination in time on MRI, that can either be done 2 ways. So you can have either contrast enhancing lesions or new lesions over time if you have multiple scans. Then a last thing that wasn't mentioned by Vera is that biomarkers, and especially biomarkers in the CSF, that are an indication of inflammation in the brain can also be used as a risk factor for dissemination in time. So it's what we call the oligoclonal bands, and you see here an example of the abnormal protein production, which are the oligoclonal bands, compared to the absence of these bands. And these are indicative of intrathecal inflammation. And it's used as a prognostic factor within these criteria. So as we've been discussing before, if you see these oligoclonal bands, you know that there is a high risk of subsequent inflammation. And that is the reason why they are incorporated in the diagnostic criteria to, well, prove additional evidence for ongoing disease activity, so ongoing disease activity over time. And I think the new kid on the block is the kappa-free light chain. We don't use it in Amsterdam. I know they use it in France, and I know they use it in Denmark. The idea is that you get a number. So instead of this very difficult investigation that you have to do by eye, these oligoclonal bands, I mean, you can ask me, why is this now so different from this? It's a difficult examination, and you have to have 2 raters in our clinics to diagnose the oligoclonal bands. The kappa-free light chain is more easy, so you get a number with thresholds, and that is basically it. So I think, well, the question now in our clinic is if we are implementing those. And I expect that we will see more of that also in literature, that the diagnosis is made on kappa-free light chain. So, yes, the diagnostic criteria of 2025, we don't know them yet, but again, asymptomatic optic nerve involvement can also be diagnosed on imaging, and we have new MRI features to improve specificity and make an earlier diagnosis in some cases where it's sometimes difficult, such as the central vein sign and the paramagnetic rim lesions. And what is also an important thing is that it's now possible to diagnose MS in asymptomatic cases, which we would have called radiologically isolated syndrome, but in some cases we will be calling that multiple sclerosis in the near future. And yeah, of course, the question is, why do we do that? Again, we want to have a diagnosis as soon as possible to prevent disability and also future damage. Any questions on this until now? Because this is the more theoretical summary of everything that I've told. For everybody who wants to have a look at the graph, you can have a look at the slides on the Actrins side if you have access. But I think the most important thing to remember is that it's getting increasingly complex, but that it's all markers for dissemination in space and dissemination in time to be as sensitive and specific as possible for a correct diagnosis. Now, why all these changes? And I found this while looking at the reasons for all these diagnostic criteria. And actually, this paper by Massimo Filippi nicely showed the difference in time to diagnosis. So these were the criteria where you made a clinical diagnosis, so based on the next relapse. And there the average time was almost 60 months. But now with the new 2017 McDonald criteria, the median time to diagnosis from onset is 3.2 months. So that is quite an improvement of the time. Now, if we go back to the patient, we, of course, did an MRI scan. And see if you can spot the problems with these not so good MRI scans. So, Farah.
There's another problem.
Here is a problem. Here?
There's a problem. Yeah.
This is a problem.
There's another problem popping up now.
Here, this one?
There.
A tiny problem. Yeah.
Yeah.
Very tiny problem.
Diagnostic problem. That's paraventricular.
Yeah. This? Also a problem.
Yeah.
The third problem. And I found one, but I had the contrast series. It's very difficult to see. This is also a problem.
Yeah.
Yeah, very tiny, but it is a problem in this case. And now if we go down, also difficult to see here because of the contrast. Oh, but this. Easy to miss here, but this is an infratentorial problem. So we have a periventricular problem, we have an infratentorial problem, which is dissemination in place. Here, it's getting more clear here. And if we have the contrast scan, you can see that the problems here don't enhance if you look through the images. But if you go down, you see a bit of enhancement here, I think. And more pronounced enhancement here. So this is also contrast enhancement. So this is dissemination in time. Now the only problem is the question, does it fit her symptoms? So she had, I think, a spinal cord syndrome with the ascending sensory problems. So we requested a brain scan, and now we have to do a spinal scan as well. And this is the spinal cord scan. And what you see here is that there is a focal lesion. It's one segment and it's a little bit on the periphery. So that is an extra criterion for dissemination in place, because we now also have a spinal cord lesion. So you can see how difficult it can be and how subtle the MRI problems can be. You sometimes really have to look for the tiny lesions in certain areas. But eventually you can make a diagnosis, and that again is possible, or is, how do you say that, important for the treatment. Any questions on this? And I say it's sometimes difficult to see the lesions, but it's also difficult to make a mistake in the diagnosis, and that is what we will be discussing in the next lecture on how MS mimics can also make life quite difficult. Thanks.
So not everything is MS. There's, of course, in nature, there's a potpourri of things you can be sick of and suffer from. So let's dig into the differentials, because you can have lots of different symptoms and they can mimic MS, or also you can have MS that mimics other conditions. So you've learned about MRI and you've learned about the diagnostic criteria where to look at. And now we look at, first in part 1, MS mimicking other diseases. So this is MS not looking as it should look, but looking like a different condition. And then we dig into part 2, into other diseases mimicking MS, which of course is very important. So what you saw until now was this classic Charcot type with the Dawson's fingers and everything. You're now experts already. But there's also other forms of MS, like the tumefactive type that is like a tumor, or there are rare types like malignant type Marburg. There's concentric sclerosis type below. Those are rare forms that are not classically presenting as MS, but are considered MS subtypes of a rarer type. And there's also the issue of solitary sclerosis, which is sometimes considered a subtype of MS, sometimes not. There are, in fact, different manifestations of MS that could look like a different entity, but are in fact MS. And because we have no time to look at all of them, we look at the tumefactive type, because this comes along quite frequently. Tumefactive MS, looking like a tumor. So Dr. Strijbis, what are the clinical facts here?
Yeah, so the clinical fact is that people can experience subacute clinical symptoms, and with subacute I mean that there is never an acute onset where people go from nothing until the worst, because that is obviously mainly stroke. And it basically depends on where it's localized.
Okay.
It's in the brain. It can mimic most of the symptoms. I think you can see quite severe neurological problems, hemiparesis, sensory disturbances.
And do we know why some have Charcot type MS and others develop this tumefactive type?
No idea.
No idea. Yeah, I also couldn't find anything that made a lot of sense when I dug into it. Thanks a lot. But this is what this tumefactive type looks like. This is an example of our own clinic. 6-year-old girl had acute ataxia and came to got an MRI, actually came from peripheral hospital with a question, did she have a cerebellar infarction? Because this is where ataxia sits, yeah? And she got this MRI. We did not find anything in the cerebellum, as you can or cannot see on the lower left side here. So that was quite surprising. But we found those giant lesions in the parietal lobe. Hang on. So as you can see here, that it looked like a central cyst or necrosis, yeah, but it was all water iso-intense on the T2 weighted images also, complete suppression of signal on the T2 flare, which means it's like pure water. There was edema around it, and as we can see here on the diffusion weighted images, that was vasogenic edema, and then there was at the very outer rim of the edema, it was cytotoxic edema, which is proven as this line of diffusion restriction. And where we had cytotoxic edema, we also had blood-brain barrier breakdown. And as I told you before, blood-brain barrier breakdown is very indicative of acute inflammation because, for example, there are inflammatory cells. We did MRS, so spectroscopy, and as you just now have to believe me, spectroscopy was normal, and there was no hemorrhage and no sign of neovascularization, so no tumor vessels on the SWI. This is a summary of this, and as you can see here, very important, that's why T2 weighted images, classic T2 weighted images are also important, because you can see here that the cortex was not invaded by this lesion. This is very important as a differential because, of course, could it also be a tumor? Well, bilateral tumors actually do exist, yeah, also in gliomas, which would be a malignant primary brain tumor. But for the age group, that would be very unusual. What is also striking is that the patient nearly recovered within 3 months. So the cysts remained more or less, got smaller, but the contrast enhancement already within a month under therapy, and it was glucocorticoid therapy, went away, and then also the edema vanished. And some gliosis was remaining, and is actually still remaining even 15 months after the initial presentation. Again, why was this no cancer? This is a true glioma, true bad brain tumor for comparison, and you can see in a real like malignant brain tumor that the cortex is heavily invaded. Yeah, so unlikely age, gliomas invade the cortex, MS doesn't, at least not in that way, also not tumor-factive MS, it remains in the white matter. What is also striking is that there is vasogenic edema inside the enhancing rim of this girl as we go back. So and that is something that you can't see in glioma. In glioma, you have necrosis and then comes the enhancement, while in brain tumors, you have no lesion here that only has vasogenic edema. So this makes this very suspicious of tumor-factive MS because a glioma just in some ways doesn't behave that way. And also, as you can see here on our glioma case, this is not a cyst here. This is necrosis. It's filled with dead protein, dead tissue. And in our 6-year-old girl, we had something that was water iso-intense that truly looked cystic. And while there are cystic primary brain tumors, this is not very typical in combination with blood-brain barrier disruption in that way. So that made it look like a tumor-factive MS. And also the spectroscopy was normal. That is also a very strong hint. If you have a malignant brain tumor, you'll have a pathological spectroscopy. And in this case, the spectroscopy showed hardly any deviation.
Vera?
Yes?
That was lactate though.
There's a little bit, yeah. In this one, I don't know. It was reported as normal lactate. Okay. Yeah. Right, so this is tumor-factive MS. So how about MS mimicking metastases? So in this case, actually, we handed in for a computer-assisted analysis software that we may want to buy. And my colleague says, yeah, no, why didn't you hand in any MS case? And I said, I did hand in one MS case. It's this case. No, this is a metastasis case, they told me. And I said, no, I already put it into my lecture for today for Istanbul. And so believe me, it's an MS case. So sometimes MS lesions can look nasty, like brain metastases, yeah, that are punctate and enhancing. What could help us to rule out brain metastases in this patient? And I don't know if you can see the metastases. It's here. Let me add an arrow for you. Hoppy. So as you're a radiological expert, the metastasis is usually at the edge of gray matter and white matter. It's just under the gray and white matter. While this thing here is in the deep white matter, which is an unusual location for metastasis. Yeah. So, but still, sometimes you can be fooled in both directions. And there are, for example, young people who have brain metastases from melanoma. We've seen people in their early 20s, and they arrive as suspicion of MS, and then it turns out they have brain metastases. Or I once had a case of a guy who had an MS diagnosis and who developed brain metastasis from melanoma, strictly, by the way, under fingolimod, which is suspected to enhance this. And he developed brain metastasis, and the brain metastases were not observed because they thought, okay, it's all MS lesions. So that was quite a bad decision. So it can go both directions, and sometimes very tricky. Let's now discuss other diseases mimicking MS, because there's a wide range of those conditions, and we have only limited time. Do you have any questions regarding MS mimicking other diseases? Like, so mainly it's tumor and infection also. In Holland, we see very rarely brain infections of CNS invasive agents, but can happen.
I think also an important addition can be the duration of the contrast enhancement. In these cases, that if you do a repeat scan,
exactly.
Same exact contrast enhancement, that is very abnormal.
Yeah, because MS lesions, they lose their contrast enhancement after a while. And if it persists, it's indicative of something else. Not necessarily cancer, but it could be some other inflammation that is more persistent, like sarcoidosis, for example. There was a question in the very back.
How about stroke?
Strokes, yeah. Strokes, I will show you cases. So the classic strokes where a proximal vessel closes, produces larger lesions. Those could still be like, I don't know, a Marburg variant of MS where you have giant lesions, but at least it doesn't mimic the small lesions that you see in Charcot-type MS. And also, stroke has a clear evolution, usually, especially when a larger vessel closes, because you'll see persistent deficit. And if the stroke isn't cured, then you also see very often that the deficits very, very quickly gets worse and aggravates. So stroke has a high mortality. And in MS, that's usually not the case. Yeah. But as we'll see in a moment, vessel imaging can be very important. So let's go to the second part. So first of all, I would like to meet MS's extended family, the cousins. Yeah, I call them the cousins, and the cousins have the striking names ADEM, MOGAD, and NMOSD. So the last one the parents didn't choose very nicely. So, and they're also demyelinating conditions, but they're based on different immunological backgrounds compared to MS. So let's first start with ADEM. How about ADEM? Dr. Strijbis, can you tell us something briefly about ADEM? Like, what do I need to know about ADEM patients? Age-wise, how does it happen?
Yeah, so what you need to know about ADEM patients, it's typical children.
Yeah.
With very severe neurological complaints. So I think the girl that you showed,
6-year-old?
that had tumor-affective MS.
Yeah.
I think in the differential there would have been ADEM.
ADEM, definitely, yeah.
Yeah. So disability can be anywhere. So ataxia, but also mostly quite severe. I think that's the most important thing. You see a lot of, but that is for you. You see a lot of abnormalities on the MRI scan.
On the MRI scan,
Yeah.
okay.
Yeah.
Do they recover, the patients, or?
Yeah,
Yeah.
they do. But some people or some kids go into an MS diagnosis. And also some ADEM patients actually have MOGAD.
Oh yeah.
So that's the new thing, that in ADEM, which used to be an entity that was on its own, in some cases we can find MOG antibodies, and there the prognosis is slightly different.
And then they have both conditions, ADEM and MOGAD.
No, it's an ADEM presentation of MOGAD.
Ah, right.
So you can also have an optic neuritis presentation as a MOGAD, but it's an overlapping entity now.
Okay, well, luckily I bought some cases, brought, not bought. I would never buy for a case, no. Anyhow, so what is ADEM? Yeah, exactly. So this is the summary of the clinics. So how to treat it? Let's keep it a bit shorter, but we know it's mainly kids. And is this infection thing still on with ADEM? Do they need to have like infections or vaccinations?
No, not necessarily.
Okay.
Yeah, but there is an association.
There's an association, okay, but I can't say it's not ADEM when the kid didn't have an infection or so. Okay, right, okay.
Oh, and I forgot to tell, but that is two important things. Kids, I don't normally see them, but seizures are quite important, and also a loss of consciousness, so coma.
Coma,
It can be
okay.
quite if it's very severe.
Okay, right, okay. ADEM imaging, I brought you a case, also I think it's an in-house case, yes. So here I think the sun will unfortunately cause us not to see the lesions very well. If you were in a dark place, you'd see them much better. But here the white matter is not clean, here in the thalamus the white matter is not clean. And also infratentorially, maybe you see here the left thalamus that is not okay. It's hyperintense compared to the right one. Infratentorially, here at the fourth ventricle, there's also too much signal going on. And this is a actually very subtle case because, as you'll see in a moment, ADEM has also many phases. So, but those lesions typical in the peripheral white matter, in a case of here a child of school age, that is very suspicious of ADEM with the typical neurology. There can be contrast enhancement, but not necessarily. Here in this case, we suspected that there was a very subtle contrast enhancement, but it was a bit dubious, but it can also look quite differently, as I'll show you. There is also a complete resolution of lesions over time to be expected. But, as I said, the phenotype is very variable and there can also be complications from normal ADEM. So what we see is also very much stronger cases, like this is a different case with a lot more edema. And those stronger cases also have, by tendency, more enhancement than the very subtle case I showed you a moment ago, like here, for example. And as I said, the lesions are very often in the peripheral white matter, but not necessarily juxtacortically. So as you can maybe see here, there's still some white matter between the cortex and the lesion. Lesions can be smaller, can be very tumefactive, and the number of lesions is also highly variable. So there can be kids who have like only 1 or 2 lesions and others who have like dozens. And if you see lesions in the thalamus, like in our case, it is highly indicative that this is not an MS case, actually. And it relatively spares the corpus callosum, while in MS, you would see a lot of corpus callosum lesions. And it's usually monophasic, so that you wouldn't expect any new lesions. If you see new lesions, then there's more likely degeneration into MS happening. But usually, the lesions all pop up, they all occur at the same time, and they all vanish. You know?
And also here it's interesting to see the contrast enhancement pattern in terms of the monophasic nature.
Absolutely.
You see that the majority of areas also enhance after
Yeah, so they all do the same thing because they're all from the same event, more or less. And they should resolve, but there are cases where something like ADEM turns into AHEM, which is a not so frequent complication, but if it happens, there's like complicative hemorrhagic cases with a far worse outcome. The cousins, I don't know if we have a lot of time, but we have to meet 2 more cousins because they're like twins, really. They're so close in the family. They're really close brothers, imaging-wise. And maybe we hear very quickly about what are NMOSD and MOGAD. Is it like different cells attacking the immune system? Who gets attacked? So that would be very interesting for me to hear.
Yeah, so those are the new diagnoses. These used to be MS. And then came NMOSD and do you need me to?
You better.
Yeah. Yeah, no problem. Yeah. So these are basically new diseases. These used to be called MS. So also people were diagnosed with MS, but after the discovery of specific antibodies, aquaporin 4 in this case and MOG antibodies in the MOGAD case, we know it's a very distinctive disease because in MS you don't have any antibodies causing the disease. So the NMOSD is typically the optic neuritis and spinal cord. That is also why it used to be called opticospinal multiple sclerosis, but we know better now. There is a difference in patients between the two. Because you said they're cousins, they're really closely connected, but the prognosis is different. The prognosis in MOGAD is far better than in NMOSD, because in 70% of cases with MOGAD, there is no subsequent relapse, while there is a high risk in NMOSD. And why is it important to distinguish it from MS? That is because the treatment is different. MS treatments can actually worsen NMOSD. And a second thing is that the prognosis is also different because where you see in MS patients that the inflammation diminishes over time, in NMOSD you can still have a risk of new episodes even when you're 80. And if you have a relapse, it's far more severe than in MS, and it also doesn't recover quite well. So in comparison to MS, if a person with NMOSD has a relapse, we go into treatment, acute symptom treatment, quite aggressively. We start steroids, we start plasma exchange just to prevent any new disability happening. And how do you treat it? Important question, CD20 therapies. I think those are that is the most important therapy. So in that sense, if you have a differential diagnosis, it's now more easy. You just start CD20 therapy, also in cases where you think of NMOSD, but where you don't have the antibodies yet. So that is
rituximab.
Rituximab, rituximab for life.
Do I have? Now I have 2.
Oh, you have 2. Oh, okay, no, cool.
Hang on.
Yeah, I'll keep it.
Right. Okay. Yeah. So imaging-wise, it's a bit difficult. So let's, for example, start with NMOSD. So what we see very often is a combination of optic nerve changes and inflammation with cervical spine inflammation, and that is more extensive than in MS. In MS, you had very small lesions, while in NMOSD, but also in MOGAD, you see very long, extensive transverse myelitis. It's LETM. So this is more than 3 spinal segments by definition, and can go much worse. I'll show you in a second. What is quite typical is also that you see very bright spots of inflammation, like for example here on the transverse image. Those are also said to be NMOSD typical. And you also see a lot of gray matter involvement. And you can see leptomeningeal enhancement, which is something that is very atypical of MS, on the other hand. And regarding the optic nerve, in MS we often see anterior small lesions, so lesions that are close to the eyeball, while in NMOSD we see more posterior, more symmetric lesions, very often at the chiasm. Oh, and by the way, often we also see brain lesion negative cases in NMOSD. So the brain is not really affected, it's relatively spared. Because it's an aquaporin 4 associated disease, you will find lesions, if you look at the brain, very close to areas of the brain that have a lot of expression of aquaporin 4. And this is usually around the ventricles. So we look at lesions around the ventricular system, hypothalamus, for example, the aqueduct. If we see a lot of lesion load there, also not really like those ovoid lesions, but more like a longer coverage of lesions around the ventricles, this is very suspicious of NMOSD. Sometimes also following the corticospinal tract in some places. So always ask yourself, where's the aquaporin 4 expressed mainly, and then look if this is the lesion focus. And as you can see here also, those very well-defined lesions are not so much in NMOSD. It's more like not well-defined and more area-covering lesions around the ventricles. Still, if you have advanced MS and you don't know, then you can also have like more confluent lesions. So sometimes it can be difficult. In MOGAD, we have a similar issue. It is also causing optic neuritis and spinal issues and can relatively spare the brain. And you also can see leptomeningeal enhancement in the brain, also with seizures. I have no image for that because I never have a patient that had this. But as you can see in this MOGAD patient, this lesion is extremely long here. Yeah, so it starts at T1 and goes down all to the cone. And those cone lesions are also very typical of MOGAD. So if something goes down to the cone, think of MOGAD maybe. And also think that, it's not only long and extensive, but it's also mainly in the central spinal cord. And as already said by Eva, it's associated also with ADEM, or it's more or less the same expression. Yeah.
I was just wondering about your workflow. So if they didn't do the antibody tests yet, and you see the scan and you think, well, maybe this is MOGAD, then you give feedback back. Do you, as a radiologist, then also get the results as a sort of confirmation for yourself?
No, this is a big problem. So we hardly, unless we follow up the case, for example, in an interdisciplinary meeting, we never get any feedback. Yeah.
So I would imagine if you do, you also learn.
Exactly. I've already written a suggestion for computer program development on how to train radiologists better on follow-up reporting. But until now, none of the big vendors was interested in collaborating on this idea. It's not only in MS, but also tumor, for example. No, but unfortunately, only in the follow-up we see the results. Sometimes if a case is very interesting, we jot it illegally down and then track it later. Yeah. And as said in my initial talk, in MOGAD, very often you also in NMOSD you will see paraneuritis of the optic nerve. So this is so it means that the optic nerve itself is not so much inflamed, but that the neural tissue around the optic nerve shows the inflammation.
I think what is also, previous lecture I said that time is brain in terms of MS, but that is really the case for NMOSD and MOGAD. So in terms of NMOSD, there is evidence that if you start plasma exchange sooner on, within the first couple of days, the prognosis is actually better. And in terms of MOGAD, there is now evidence that says that if you start plasma exchange or acute relapse treatment sooner, that the risk of a next event is smaller. The problem is that the antibodies take sometimes weeks. So to get a confirmation of the diagnosis, we are 2 weeks in. And that makes us to sometimes decide on plasma exchange based on only the radiological picture without any confirmational diagnosis.
Yeah. That's interesting for us to know, actually, because for us that's very often not so, we're not so aware of this and about the implications that has, really. Yeah. This is an overview slide, maybe more for your own record. So basically, the upper part here shows typical NMOSD, which is like very extensive central lesions, very often also one big cervical lesion instead of several lesions. While in MOGAD, you'll see the same issue, but very often more downward, for example, in the cone. And in MS, you have like lesions anywhere, very often many lesions that more form a patchy confluence over time when the disease is not very well under control. And in MS, of course, it's primarily a white matter disease, while in MOGAD and NMOSD, the gray matter is much more affected. So part 2, how can we find the fake? We want to find MS, but not the real thing. And it's not like here what happened in New York recently, that the real person comes along to confirm that the others are fake. Yeah. So we have to get better indicators on how to rule out MS by confirming, for example, that something else is the case. And we have a long list of differentials. And this paper I can really recommend to you. It's from a guy I always call Geramus. It's not really his name, but it's a recent paper on mimics of MS with very good explanations on why something is or is not MS. And I can show you the link if you want in a second. But the tumor, small vessel disease, vasculitis, encephalitis, infection, intoxication, genetic disorders, all of them can mimic MS. And we are here to find out how to differentiate a little bit more. And
there's a lot of weight on the shoulders of radiologists, because perhaps you can remember that a part of the diagnostic criteria is that MS is not another disease.
Yeah.
So that you've reliably ruled out any other disease.
Yeah.
So then we go back to the radiologist and say, are you sure? And then
sometimes we sit there with 3 people and because we just can't conclude and say, yeah, but this lesion, but if you count in that lesion, then it's more MS, don't you think? And I say, yeah, but all the other lesions, could we maybe mix it, that we say it's MS plus another thing? And yeah, maybe try, and let's see if the neurologists swallow it. But a very important issue is small vessel disease. So you heard that more and more older people, and older, I mean 50 plus, so it's a lot of life still ahead of them, get diagnosed with MS nowadays, and compared to the past when it was only more like a 30 and younger disease. And when you are 50 and older, and you may have accumulated smoking over the years, diabetes, or you have chronic migraines, then you accumulate what is called small vessel disease in the brain, and that means that you get those weird patchy things here everywhere in the brain from tiny infarctions in the brain. So on the left side, the left brain shows you small vessel disease in one of our cases, which is just a side effect of aging, whether it's pathological or good aging, I don't know, but you just accumulate this during your life, and you have to differentiate this now as a radiologist from MS, which is the image on the right, and this can be sometimes very difficult. Of course, there are like indicators like, for example, is the lesion like very asymmetrical and not very well defined? Then we have, and is it more in the deep white matter? Then we have a tendency to say in an older patient, it's likely vascular microstroke. Well, when it's a younger patient with a more ovoid lesion, then we have a tendency to say it's MS. While of course the lesions can be in the same places really, but of course, location is an issue. For example, small vessel disease will not give you those juxtacortical lesions right under the cortex. So if I see those, then I can quite clearly say it's MS rather than small vessel disease. We also look at other hints, like for example, remember our corpus callosum with the Dawson's finger. So usually that is also quite a good hint, because the small vessel disease will not produce those Dawson's fingers very much. Well, the Dawson's fingers are highly indicative of MS really. Also, we haven't talked about the temporal lobe really. The temporal lobe is like a hidden indicator for MS lesions. It's not an official location, but if we see a lot of anterior temporal lobe lesions, then it's also more MS rather than small vessel disease. And of course, we look at the central vein sign if we can. So if our lesions show a central vein sign, it's more indicative of MS, less indicative of small vessel disease. So this is our biggest enemy you've met of all the not related conditions. Let's go to vasculitis. Vasculitis is not small vessel disease in the classic sense, but it is really an inflammation. Can be caused by antibodies, can be caused by infection. There are a lot of reasons to have some kind of vasculitis. There are also many forms of vasculitis, like for example, angiitis due to lupus disease, as shown here. And let's maybe skip the clinical part, but as you know, there are trillions of reasons and different vessels are affected. And if you have a bigger vessel affected, then you have a bigger lesion. If you have a smaller vessel affected, then you have a smaller lesion. If you have one vessel affected, you only have one region affected. If you have a generalized angiitis, you have many different regions affected. So this is something to bear in mind. And vasculitis is really painful to differentiate from MS sometimes. So it's the the MRI presentation is highly inconsistent. That makes it so difficult. So this, for example, is another vasculitis. It's also vasculitis. It's primary angiitis of the CNS, and that, why can that not be a very aggressive special form of MS, for example? So that can be difficult. And what helps us sometimes is that we, in those cases where vasculitis is part of the differentials for clinical reasons, that we also have vascular imaging. And then if all the vessels are normal, that doesn't mean the person cannot have vasculitis. But if we find something that is not normal, then we have an indicator to say this is likely vasculitis. And for example, in this case, if you look at the middle cerebral artery on the left side compared to the right side, you can see that here everything is narrowed, stenotic. So this is indicative of vasculitis. We also use special sequences to show larger vessel inflammation, like for example here in the peripheral parts of the middle cerebral artery. And then we can say, okay, MS is highly unlikely in this case. It's those lesions in the white matter are likely caused by vasculitis. A special kind of vasculitis has a Turkish name, Behçet's disease. What is this Behçet thing again, Eva?
Yeah, we have the expert here. We were discussing over lunch because we don't see a lot of patients with Behçet in Holland.
Despite the fact we have a significant Turkish population in Holland,
but still,
they left the Behçet disease at home, maybe.
Yeah.
It's quite common in Turkey and the Middle East area. There's a genetic disposition as well, and this is actually a clinical diagnosis. Behçet disease, it causes some overlaps, genital ulcers, some inflammation within the eye, and some vascular thrombosis or aneurysms, and also one of the parts of the disease is that neurological involvement. So Behçet's disease can cause like 5 to 10% of those patients have some neurovascular disease, which can be more divided into like parenchymal diseases like this. Mostly the lesions involves the mesodiencephalic region and the brainstem, and another involvement is sinus vein thrombosis, can cause some thrombosis in the dural sinuses. So this is not exactly like MS. This is not an autoimmune disease. This is also not an completely autoinflammatory disease. This is like in between of within this spectrum. So this is a special disease, and the treatment is also so different than MS. These patients have like more cognitive involvement. They tend to develop brainstem atrophy easier. So they need to be diagnosed and treated like as soon as you can. This may cause really disabled person.
Yeah, and the most important thing I think is that the majority of anti-inflammatory therapies you can use over different autoimmune diseases, but there is one that can actually make MS worse, and that is TNF-alpha treatments, TNF-alpha inhibitors. And those are prescribed as a very effective medication for Behçet, but also sarcoidosis, and I believe also some cases of vasculitis. And for that reason, you basically want to make sure that it's not MS, because you can aggravate and really aggravate the diagnosis. Yeah.
Yeah, but as stated, basically what we're looking at in Behçet's disease is mainly brainstem lesions and hypothalamic, sometimes corticospinal tract lesions. But it can also have like patchy enhancement. And what gives us a clue in, for example, vasculitis and Behçet's disease is also that, of course, very often those are systemic diseases, as we show. And this is very important for us because if you say your symptoms are mainly neurological, then in some centers, like for example in England, the patient doesn't even get seen by a physician, like a clinical physician. They just get sent straight to the MRI scan, and we don't know anything about whether something is located also in the lungs or the abdomen or so. And then we are confronted only with an MRI scan, and apart from that, nothing. And that can, of course, cause misdiagnosis of other autoimmune demyelinating diseases. Sarcoidosis, for example, is a very good candidate to be mixed up with MS if you haven't seen a lot of those cases. Sarcoidosis means like the flesh-making disease or something in Greek, right? What was it again?
I'm not sure if that's it, but you see granuloma
those
also
are
resembling.
granulomas, granular diseases, But what is important is that this is also one of those conditions that can happen in the brain, sarcoidosis disease, but they usually happen outside the brain. So it's very important that you also know what's going outside the brain if you find lung manifestations or other manifestations of disease. And but for example, sarcoidosis can cause those granulomatous lesions in the brain. So in one subtype of neurosarcoidosis, so there's also leptomeningeal sarcoidosis, there's dural sarcoidosis, but you can be confronted with patients who only have brain lesions, and then this can be very tricky to distinguish from MS if you don't know any other if you don't know any other information about the patient. Maybe what could be a hint is that sarcoidosis lesions make no choice on where they're located. If anything, they're more basal in the brain, close to the vessels, while MS lesions, of course, have the 5 typical locations. Here, for example, this is also difficult. And then our last case that I brought is tuberculosis. And tuberculosis was actually nearly dying out, but is now heavily coming back. And tuberculosis can cause neurotuberculosis with tuberculomas. And those tuberculomas can look like MS lesions also sometimes. What might be helpful is that the tuberculomas have more roundish lesions that are completely round, and not the ovoid features. They also do not have the typical distribution of MS lesions, and more importantly, they usually enhance, while MS lesions, you have, if anything, a mix between enhancing and non-enhancing lesions. And also the edema in an infectious lesion, because tuberculosis is a bacterial disease, you'll see a lot of edema around the lesions, which is not so typical of MS lesions, at least not in the classic Charcot sense. Are there any questions until now on all those mimics? So you've now realized that there's like infection, tumor, chronic vascular disease, other autoimmune diseases that can all mimic MS lesions, and that we have to follow cues very narrowly to get to a diagnosis. And sometimes, as I put it here on the last slide, only time will tell. So sometimes people just have to come back, and we have to hope that they have developed new lesions that prove a dissemination, because that is what the alternative name of MS is, encephalomyelitis disseminata, so disseminate infection, not infection but inflammation. And but there are many other mimics, and we have 2 times a week an interdisciplinary meeting where we just discuss those patients really who have maybe MS, maybe not, and sometimes it's very difficult. And with that, I'm already at my last slide, and I think we're well in time.
We are on time.
Yeah.